Hi, everyone. Welcome to our perinatal equity webinar today. I will give us a few minutes to have everyone come in and join us. All right, as everyone continues to trickle in, I'm going to go ahead and get started. Welcome, everyone. Thank you so much for joining us for our perinatal equity webinar this quarter. We are going to be talking about creating a respectful care environment and some lessons from a trauma-informed approach. So we are really excited to move forward into this conversation with you all and continue building towards improving patient outcomes. Just to remind everyone, if you want to receive nursing contact hours for this webinar, please look out for an evaluation link in the next 2 days that you should receive so that you can complete the evaluation and get those contact hours. You must be in attendance for the webinar for at least 50 minutes for that contact hour to be awarded per the BRN so that we can stay in compliance there. So keep an eye out on your emails. All of you are muted upon entry. We will not be doing a live Q&A, so please look for the Q&A function in your Zoom bar below. We'll do our best to answer some of those questions from both the CMQCC folks and from our speakers for today. You're welcome to use any of the slides that we're using. Just if you modify or add any slides, please remove the CMQCC logo and add your own. You will have access to the webinars and the slides in the next couple of days as well. Again, for those of you keeping an eye on your emails, looking for the evaluation, we really would welcome your feedback and recommendations on how we can continue to improve these webinars. Whether you're involved in a CMQCC program or not, we want to take advice from all of you who are attending and listening, since there are so many of you that come to each of these webinars every couple months. Again, just want to review our inclusive language notice from CMQCC. We recognize not everyone who can become pregnant or can give birth identifies as a mother or as a woman. So we're going to be using the above terms: birthing people, mother, maternal, they, them, she, her, pregnancy capable person, interchangeably to represent everyone in this space who's receiving maternal health services. We also want to recognize that the term family is going to be very inclusive for anyone that the pregnant or postpartum person designates, including partners, support person, loved ones, as well as reviewing that clinician is a different term than provider that we'll be using. Our objectives for today, we were going to be describing the fundamental principles of trauma-informed care through reproductive health lens and discussing more practical approaches for trauma-informed care as part of this respectful perinatal maternity care. We're going to be evaluating the role of unconscious bias and the way stereotypes play and the burden that they place on historically marginalized people. We also recognize that privilege and understanding unconscious beliefs, racial attitudes, identity, stereotypes, and bias as they relate to racism. To reiterate, we're going to be sharing the recordings and slides with you all on the CMQCC website under resources and toolkits. So you should see that within the next couple of days if you all want to go back and listen, or you know others who would like to listen who could not attend today. I'm going to be sharing our two wonderful speakers for our webinar today, Dr. Sarah Johnson and Sherilyn Kelly. Dr. Sarah Johnson is an OBGYN at La Clinica de la Raza in Oakland. She's also a consultant who focuses on trauma-informed care and quality improvement. She's currently advising UCLA and UCSF ACE's Aware Family Resilience Network, as well as CMQCC. And Sherilyn Kelly is the Executive Director of Perinatal Services at Miller Children's and Women's Hospital in Long Beach. She has a long history of engagement with CMQCC programs, including leading the engagement with the Birth Equity Collaborative pilot in 2019 with CMQCC. So we are so excited that they're both here with us, and I will be passing it off to Dr. Sarah Johnson to continue her presentation.
Thank you so much, Savannah. I'm just going to work on sharing my screen real quick here. There we go. Okay. let me get this back to the beginning here. Okay. Thank you so much, Savannah. And thanks to everyone who's here for sharing your lunch hour with us. I'm really thrilled and excited to be here with you all today and to get to contribute to this amazing series. I'm coming, as Savannah briefly mentioned, from the ACEs Aware Initiative, as well as the clinical perspective. And the ACEs Aware Initiative is a first in the nation effort in California to prevent and address the consequences of adverse childhood experiences and their effects on health. And we really at ACEs Aware want to engage with and support this community. So I wanted to give a shout out there and make sure you all know that we exist, and we'd love to hear from you and support your work. As Savannah mentioned, I'm going to be giving a talk entitled Providing Respectful Perinatal and Maternity Care, Lessons from a Trauma-Informed Approach. As Savannah mentioned, I'm an OBGYN at La Clinica, which is a community health center in the East Bay. I've worked there for my whole career and volunteered there in high school. I am an advocate for trauma-informed care and work in that space because it's an area where I really feel most connected to why I went into this field. And I'm also, in giving this talk, aware of my intersectionality. I am a physician, but I'm also a human being, a patient, and a mother. And I also am aware of areas where my life experience might not give me as much awareness and visibility. I identify as white. I am a physician in a complex dynamic. So I'm thinking about all those things as I talk to you today. Savannah went over our learning objectives, and I just want to highlight that respectful maternity care is an urgent and important issue that's very much related to health equity. And today we're going to think about how considering trauma and resilience and the adoption of a trauma-informed approach can add to and enhance our efforts to create respectful maternity care. Just a quick note about this topic. Considering and talking about trauma and adversity can be challenging, either in the moment or in the following days or weeks as we kind of let the thoughts roll around in our consciousness. And I want to encourage everyone to take note of your own needs and provide yourself the care you would offer to your patients in that respect. And in keeping with that, I want us to all just take one moment to check in with our own nervous systems and start with a deep breath. I'm going to do that too. Okay. So why are we talking about respectful maternity care today? This is an urgent issue that's brought to our attention by reports from the community, by research highlighting that patients under our care are not having a positive experience and often, in fact, have very negative experiences. This slide is from a recent study by the CDC that echoes the findings of previous research. They asked women about their experiences during maternity care, and really a quite alarming number reported experiences of mistreatment. This was defined as receiving no response to requests for help, being shouted at or scolded, not having their physical privacy protected, or being threatened with withholding treatment or made to accept unwanted treatment. And this is a really difficult slide to look at in some ways. It's quite alarming, and it's something that we really need to sit with. It's hard to hear because it's so out of alignment with our goals for why we're in this field and what we want to do. It's important to note that there's an inequity visible on this slide, that Black, Hispanic, and multiracial patients experienced mistreatment at higher rates than other patients. And this is mirroring the inequities that we see in other outcomes of focus, like severe maternal morbidity and mortality. And this is not without consequences for inequities. Think about the mental health complications, such as childbirth-related PTSD that can arise with this, or the lack of trust. How do experiences like this affect the trust that we know is absolutely essential to overcoming the inequities that we see in our field? So I think of this information as a call out of behavior that we absolutely need to change, and a call in also to reflect more deeply and think about why we're in this field and how we can make our actions reflect our values. So respectful maternity care is a construct that's been put forth really in response to and as a way to overcome observations such as our understanding of the experience of mistreatment. So this slide is from a recent U.S. Agency for Healthcare Research and Quality publication, and it's invoking a concept of care that honors the dignity, personhood, autonomy, and preferences of birthing people, prevents disrespect and mistreatment or abuse towards individuals who are utilizing the care. We're trying to offer a practical framework, and we're using standard elements such as consent, privacy, and safety. So as a trauma-informed care person, when I see this, I notice a lot of overlap with the trauma-informed approach, and it really strikes me how understanding trauma and resilience can add to our ability to do the deep self-reflection and practical implementation we need to achieve respectful care. And so what we're going to do now is talk about trauma resilience and trauma-informed care and how we can apply them practically as part of respectful care. So what is trauma? This definition was created by the Substance Abuse and Mental Health, Substance Abuse and Mental Health Administration, or SAMHSA, with input from survivors, experts, and researchers. And I like this definition because it's pointing out many nuances of trauma that we need to understand. So this definition says, individual trauma results from an event or series of events or set of circumstances that is experienced by an individual as physically or emotionally harmful or life-threatening, and that has lasting adverse effects on the individual's functioning and mental, physical, social, emotional, or spiritual well-being. So there are a few key takeaways from this definition that I want to highlight. And number one is that whether something is traumatic doesn't hinge on the details of the event itself, but on the experience of the event as physically or emotionally harmful or life-threatening. So that means that something that's traumatic to one person might not be experienced or seen as traumatic to another person, right? There could be a divide between two different individuals' experiences of the same event. And then this also points to the importance of context in shaping whether something is traumatic, right? Is it possible that we could, in our roles, support people in the context of events so they're not traumatic? Also, we can see how the context could make something more traumatic if there is, for example, shaming or silencing or a lack of support. An event that might be okay is suddenly capable of causing trauma. And then the final takeaway here is just looking at these effects. We can notice that trauma doesn't only necessarily lead to mental health problems, that the effects are really holistic: mental, physical, social, emotional. Trauma can affect patients' experiences of care, their relationships, different health conditions. So we need to be holistic in terms of how we think of this. Thinking about how trauma shows up in reproductive and sexual health and perinatal and maternity care settings, looking deeply at this, we can get a sense of how trauma might show up in our encounters and also see some link with health equity. First of all, if we want to be a healing force in the context of trauma, we must acknowledge and work to repair the harm and trauma that are at the root of our field. The picture to the right on this slide shows an artist's monument to Anarcha, Betsy, and Lucy, who were three among many enslaved Black women who underwent non-anesthetized medical experimentation by Dr. James Marion Sims in the late 1840s. So this is something that's woven into our field, and it's something that we see echoes of today. For example, we know that Black women receiving medical care are less likely to receive pain medication when they need it. And these experiments were undertaken in part justified by the belief at the time that Black women experienced less pain. So we're seeing echoes of this historical trauma propagating in our own field. Trauma is a common experience. Over 70% of people will experience a traumatic event, and that includes our patients and also clinicians and staff. And this is something that has an intergenerational pattern, propagates across generations, and also that has a greater burden in marginalized and disadvantaged populations, echoing that inequity issue. Reproductive health and maternity care can themselves be a source of trauma. Think about our patients when they come to us are in an inherently vulnerable position because of the nature of the care that we're providing. And this is compounded by the fact that often circumstances in OB care involve life or death experiences, true threats to well-being as well as the mistreatment and discrimination I discussed earlier that can themselves be sources of trauma. And then adding to that, an additional layer, which I think is really important for us to consider, which is that providing reproductive health care, perinatal and maternity care, can be involved with trauma, either because of witnessing challenging experiences for our patients, because reminders of our own past experiences may be invoked, or because of the experience being overwhelmed and threatened in providing care. We are sometimes doing really scary things with a ton of responsibility and not necessarily a culture of support. There are some lessons from the literature on trauma that occurs under our care that I think are really useful to extrapolate or engage with. One is that an important point noted by original investigators into traumatic birth was that there's a discrepancy between clinician and patient experiences of these events, and that patients perceive this. I had a personal experience that I'll share that really brought this home to me, where I kind of began to understand the difference between the technical focus that we often have as clinicians and the experience of patients. I had an urgent C-section for my first birth. I was undergoing an induction of labor. I got an epidural. The fetal heart rate dropped, and I found myself a patient in a position that I had often been in as a physician, being wheeled down the hall on a gurney, seeing the lights go by as I looked at the ceiling, seeing my husband outside of the operating room as he watched this happen to me, and undergoing an emergency surgery. And it was quite striking to me what, it was very scary and overwhelming. And I was telling the person who provided my postpartum visit about this experience. And I said, oh yeah, and I had a crash C-section. And this clinician, who's someone I actually deeply respect and align with, her response to that statement was, oh, it wasn't a crash. And she said that because technically the fetal heart rate had risen back to an appropriate level before the incision was made. And I absolutely see why she makes that technical distinction and why our minds go there, right? There's a clinical difference between what you do in an absolute crash where the fetal heart rate is still down and you're not counting instruments and you're doing a splash prep maybe, versus one where the heart rate's back up. But her focus in that moment on the technical aspects of the experience really felt to me very dismissive of my experience as something overwhelming. So that was something that brought home to me this lesson that two experiences can be different, and that our focus on the technical aspects of procedures to the exclusion while excluding patients' experience really has consequences. One other element that's come up in the traumatic birth literature that I think really illustrates important points in understanding trauma is that people's early traumatic experiences can show up in their birth experience. So this quote says, a person's personal experience of the event is particularly salient in whether something becomes traumatic. We've talked about that. And may be informed by her history of earlier adversity or trauma. So this is helping us understand that trauma propagates through our lives through reminders of past events. If you think about being in a car accident, someone who's in a car accident might experience activation symptoms when they go back to the intersection where that accident occurred. Well, the same thing can happen for early experiences that then play out later in life during pregnancy and birth. If you think about the example of childhood sexual abuse, for example, with the person's body being the site of trauma, similar to the intersection for the car accident, all of the changes of pregnancy, the invasion, the power dynamics, all of those elements can lead to reactivation of those earlier traumatic events. So trauma propagates through reminders. And as a final note in this deeper dive on trauma, I just want to touch briefly on adverse childhood experiences, which I think are an important lens for us as medical clinicians to be aware of. Adverse childhood experiences, or ACEs, are potentially traumatic events that occur before the age of 18. And you can see here listed 3 categories of ACEs that were studied in the original 1998 ACEs study at Kaiser Permanente. And these are 10 categories that fall into abuse, neglect, and household challenges, like having a parent with a mental illness or a parent who's incarcerated. These are obviously not the only adversities that can affect people, but these were part of the original ACEs study and are often what is referred to in subsequent studies. A really important finding of the ACEs study was that they found broad effects on later life health in a dose-response association with ACEs before the age of 18. And that these effects were not just in mental health, which were seen, but also in physical health. Actually, 9 out of 10 of the leading causes of death had a significant dose-response association with early childhood adversity. So the big insight here was that early events and later life health are connected. That echoes what we were just discussing with trauma, and that social, mental, and physical health are all interrelated. And this really reflects the wisdom that we're trying to incorporate in our field right now as we integrate mental, social, and physical health. I'll just briefly look at this list of association between ACEs and obstetrical conditions, wanting to highlight that all of the elements in that behavioral, psychosocial, and medical pattern, all of the elements that are top priorities here are experienced at greater rates in patients who experienced ACEs. So this is something that's really moving forward and showing up in mental, physical, and behavioral health. And then we know that the mechanisms of this are not just social and psychological, but also biological, that early adversity without sufficient protection and support can get under our skin in terms of how our nervous systems develop, how our cardiovascular, endocrine, and immune systems respond to events. And this can give rise to clinical conditions downstream that we see when we take care of our patients. The opportunity here, though, is that if we're able to integrate our services, we can collaborate to address the upstream cause of many of the conditions that we treat. Okay, so when we open our lens to patient experiences, to a deeper understanding of trauma, we're able to enter a new frame and move from a perspective where we're asking, what's wrong with you, to instead asking, what happened to you? What has been your experience? What in your life has led you to where you are? And how can we use that information to support and help you? And this shift is at the core of what is called trauma-informed care, or a trauma-informed approach. Trauma-informed care is a supportive, strengths-based approach to care delivery that incorporates an understanding of trauma and how it affects patients and clinicians and staff into policies, practices, and organizational structures. Essentially, we're finding a frame where we can meet our patients with understanding rather than judgment, and where we can focus on their experience and not just the technical aspects of care. I want to be clear, this doesn't mean we have to become trauma therapists or administer treatments for PTSD. In clinical practice, we're talking about providing care that's sensitive to the needs of trauma survivors, understands the broad impacts of trauma on health, and resists re-traumatization. So how are we going to do this? SAMHSA, along with its definition of trauma, has offered us a framework for providing trauma-informed care that relies on these 6 guiding principles. And I'll point out that these overlap with or support the respectful care framework I shared earlier. So we can think through these and how these add to relationships what trauma sometimes takes away, and really can create a foundation for respectful care. We're thinking about safety, trustworthiness and transparency, peer support, collaboration and mutuality, empowerment, voice and choice, and cultural and historical and gender issues. So for any situation, if we're trying to move towards a more trauma-informed approach, we can look at these principles and see how we can instill them into our work. And we'll do that in practical example in a moment. Before we move on to the practical examples, I do feel that it's important to always consider resilience when we talk about trauma, and the reason is encapsulated by this quote. It matters that we continue to have a conversation about resilience, because the meta message is that the experience of trauma does not only yield pathology. We don't want to make a mistake and fall into our pattern of asking what's wrong with you, which in many ways is our professionally trained habit. We want to broaden our investigation to what's right with you, what makes you well, what keeps you, helps you thrive, looking at patients as a whole person. But there are important nuances to how we consider resilience. Looking at this picture, in our field or our culture, we often consider resilience as the picture on the left, as one's ability to bounce back and stay fine and be okay no matter what, all on our own. And really what we need is an ecological context and definition of resilience that's more like the picture on the right, where we're considering the environment and the supports as a piece of what helps someone survive and thrive. And this distinction is important because the burden of resilience should not be on the shoulders of those who are being harmed by systems that exist. So what can we do as one piece of their care? If we are able to provide respectful care, we can consider ourselves a piece of patients' resilience. Just thinking briefly about how to bring resilience into clinical encounters that go so quickly. I try and do this by noticing patients' strengths. So someone the other day in clinic kept making jokes. She had like a 20 item problem list. It was a very overwhelming encounter, but she was hilarious and kept cracking me up and making jokes. And I mentioned, it seems like you really have a wonderful sense of humor to rely on. And she agreed, and that helped foster our connection. Another way that I incorporate this in visits is asking patients during the social determinants of health or social history component of the exam, rather than just saying, do you smoke, do you drink, do you do drugs? I say, what keeps you healthy? So there are ways that we can just bring this frame in as we go. Okay, so that was a lot. Trauma, resilience, and trauma-informed care. Let's think together about how we can apply the trauma-informed principles in our clinical context so that we can affect respectful care. And we're going to talk briefly about what we call universal trauma precautions in clinical care. And this is similar to infection precautions. These are steps that we undertake with all patients, but knowing that patients who have experienced trauma may benefit especially. And we'll think about a scenario. Myra's expecting a baby. What would it look like to engage with her in a respectful, patient-centered, and trauma-informed way? So what we'll do is, in the next few slides and examples, I'm going to just model some kind of frames of reference that we can use to start to get away from our solely technical focus and think more deeply about the patient's experience. And one is to just adopt the patient perspective and imagine her journey through clinical care. So Myra's journey involves a call to the clinic. She's going to arrive and maybe be greeted by someone in reception. She's going to spend time in the waiting room. She'll be guided back by a medical assistant. She'll engage with the clinician, and she'll maybe wrap up with a front desk person. Okay. And thinking about this, what we see is that though we're often all focused in our role on a small sliver of the patient's encounter, it's actually quite protracted and interdependent, and that each of these touch points with the clinic is an opportunity to either set up or set back the patient's experience for the next one. This means that enacting trauma-informed care is really an all-hands-on-deck team approach. There are things that people can do at each level here to make the patient feel more safe and comfortable. Even just asking the question, is there anything we can do to make your visit more comfortable, is a big step. I will say that bringing the whole team into the work to bring trauma-informed care along can be a very valuable team building experience and help people connect to their values. We had a medical assistant in our team who ended up becoming quite a champion of trauma-informed care, who shared during our team's discussions of trauma and resilience about how she had become a medical assistant because of seeing her own parents experience accessing care as immigrants who had a hard time accessing the system, and that her values in choosing her line of work were aligned with trying to eliminate that experience or provide a better experience for others. And this really affected her connection with her colleagues, the way people saw her, and her connection with the work that she was doing. So there's a real chance to elevate to elevate the work we're doing. We also want to think of the continuum of care throughout the entire perinatal period. And I think I included family planning here because especially in our current reproductive rights environment, we really need to think about preconception and where those patients are being seen. But there's a real challenge here in integrating all of the elements of care, especially with the wonderful opportunities of our expanded workforce in integrating doulas and community health workers. And I think if we don't imagine this lens of how it really fits together for the patient, we will risk creating care that is more stressful to access. One promising example that's happening at my hospital currently are meet and greets between doulas and maternity care clinicians. I think establishing those strong relationships across disciplines is essential to providing positive care experiences for patients. Okay, so having kind of brought in that patient perspective, we're going to look at different layers of care and how we can bring the trauma-informed principles to life in practice. So we'll start with environmental factors. Take a look at this image here and notice if it elicits a reaction. I've actually heard different reactions from different people. Maybe this feels warm or cold or welcoming or unwelcoming. And the point here is to just notice that the spaces we occupy provide a tremendous amount of information to our nervous systems through all of our senses that relates to whether we're safe or need to be on high alert. And this is true on the phone, in digital spaces, and certainly in physical spaces like a waiting room or exam room. So one tool for infusing the trauma-informed principles into clinical encounters is to do an environmental scan of spaces, virtual or real, and see whether they make people feel safe, welcomed, and empowered. I'll give examples of this exercise, but it really could go on forever. And it's actually a fun thing to do and engage with the entire team as well as with patient and advisors. So a safe, welcoming environment makes people seen and better positioned to use their voice and collaborate, engage. Think about the general tone of a room, the presence of security personnel, which might make people feel safer or not. Patients might not feel safe sitting with their backs to the door. One memorable comment from a patient related to the size of the seating, that the dividers in the chairs made it difficult for someone of her body size to sit, and that made her feel unwelcome and less disposed to engage in care. On the flip side, I've had patients appreciate gestures that show care, like putting art on the ceilings when patients lay down on the exam table. Signage can communicate trustworthiness and transparency by making standard policies apparent. For example, we have a policy where when we see a pregnant person, we see them as an individual at the start of the visit to protect their privacy if there's anything they want to share aside from their support person. And this is something that was off-putting to some companions in our waiting room who felt like they were being singled out when they weren't allowed back with the pregnant person. So we put up a sign that made it easy to see that the policy and show that it was universal right rather than targeting. All of this, as I mentioned, including the celebration piece, is a really great exercise to do with the whole team. Our staff really enjoys decorating the waiting room for a range of holidays. We have put pictures of clinic patients enjoying different community spaces on the walls of our hallway to feel more celebratory and inclusive. There are really many things that can be done to use that element. Okay, we're also going to think about verbal and nonverbal factors and how we're communicating with patients. And an exercise to do this is think about your own clinical practice and encounters and how you would describe what you're doing or teach what you're doing to a learner in a way that's illustrating the trauma-informed care principles. So I'll model this now just thinking through my own encounter for a pelvic exam, and this is meant to just get the gears turning, not to be an exhaustive list. Okay, so the first thing I do before I get into a room, I really try to do this, is to have a calm demeanor by just checking in with myself before I even walk in. Kind of like we did at the beginning of this presentation, just taking a deep breath. I've heard people talk about remembering an intention as they knock on the door, like to be of service. Something that just gives us a moment of awareness of where our own nervous system is, especially given the stress of our days can make us quite activated, and that may not be what we want to present to the patient to offer the care that we want. So taking a deep breath before going in. I always introduce myself and make sure people know that I'm an OBGYN doctor and my name. I'll ask them what they would like me to call them. that warm greeting to the patient and to anyone else in the room. And I usually ask the patient to introduce me to whoever they've brought with them and ask their relationship. Protecting privacy, we've talked about a little bit, but that can be a balance between peer support and privacy. So making sure that we allow people to have a support person there when they want, but also giving them an opportunity to share any information they'd like to in private. Protecting privacy also with our perinatal maternity care rooms. Sometimes people are running in and out of the room all the time, getting supplies, et cetera. Really thinking through things like that, whether the drapes adequately cover, whether the curtains work, those elements of privacy. Explaining what you're doing and why. A lack of understanding of what we're doing is so much more prevalent than we think, I've come to realize, and often a reason, affects patients who have experienced trauma perhaps more than others. So we want to be really clear about what we're doing. I often draw pictures explaining what a pap smear is, what a pelvic exam is for, what a speculum is, and encouraging questions. I like to say, what questions do you have, rather than do you have any questions, to set a tone where questions are expected. Always asking before touching and continuing to get permission throughout an exam, especially sensitive exams like a pelvic exam, and offer people options as a way to have voice and choice. This might be them picking the speculum that you're going to use. It might be giving them words to use to communicate throughout the exam that will tell you their status. I sometimes use stop or out as ways to indicate what they need from me. One question I always use with the goal of capturing anything that I have failed to, especially knowing that there will always be cultural differences or experiences that I might not pick up on or capture, is just, is there anything you'd like me to know before I do this exam, or any experience you've had in the past that I should know about before going ahead? And that hopefully, if I've established a rapport, that will open the door for patients to communicate their needs as well. So in addition to thinking about verbal and non-factors, we can think about the language that we use when we're speaking with and about our patients, and really consider how we can improve it. And this is something that's often learned implicitly in our training, and we don't often pay much attention to. So this chart here is from a document developed by colleagues at UCSF, and I will share a link to it, but it's taking common phrases like, I'm going to do the exam now, and thinking about an alternative that better incorporates the trauma-informed principles. Is it okay if we do the exam now? We're asking rather than telling whenever possible. And this can really help elevate that voice and choice and sense of control. Okay, so we talked about trauma and trauma-informed care and resilience. We talked about different tools for taking the patient's perspective and examining our environments and our processes and our language through a trauma-informed lens. And then I just want to touch on one final point, which is inquiry about adversity and trauma, which is in addition to those universal trauma-informed care precautions. And I just want to touch on this because I think that inquiry offers an important layer where we can really help recognize the connection between early experiences and current health and stressors, and show concern and support in a way that wouldn't be possible if we didn't give patients an opportunity to share, and provide universal education regardless of whether patients disclose. The goal is not to get people to tell us their stories, but rather to give them an opportunity. And when we do know what patients' experiences have been, we can collaborate with them to create individualized care plans that build on strengths and address medical issues and needs, and engage networks of care. I was fortunate to work on a really wonderful project around addressing childhood and adult adversity in prenatal care with CMQCC. And as I conclude, I'll just have a few links posted in the chat that provide resources that you can use going forward. So one is that UCSF document looking at different language shifts. Another one is a link to a website that's really excellent for trauma-informed pelvic exams. And then a third is the link to the paper that arose from our CMQCC adversity screening project, which is a clinical expert series from the Green Journal last year. And I'm running out of time, but I just want to point out that the cycle of adversity and trauma can propagate across generations, but all of these things in yellow are areas where we in our field have an opportunity to provide support and interrupt that cycle, and that we're really in a position to do a good job that is aligned with our values and offers respectful care to our patients. So I'm going to pass this over. I really would love to engage with all of you. I'm so excited to connect with colleagues on this topic. And so please feel free to offer any feedback or questions in the Q&A, and I will answer them as much as possible here. And also, when you look at the slide deck, my information is shared there, and I would love to hear from you and see reactions or how you're thinking about this. Thanks so much. And I'm excited for the next part of the presentation.
Thank you so much, Dr. Johnson. That was so informative and so wonderful. I can certainly think of plenty of times where this information would be useful at the bedside, but also personally, just in every day-to-day life, thinking about how we engage with others. So thank you so much for that. I'm going to share our next presentation with with Sherilyn Kelly. But if you wanted the information for Dr. Sarah Johnson, her information is here as well in the slides. So Sherilyn, I'll go ahead and let you get started. Thank you so much.
Great. Thank you so much, Savannah. And hi, everybody. Good afternoon. Thank you so much for allowing me to share our story on our journey that continues. I really wanted to talk about respectful accountability, and as we continue our DEIB journey, how important it is to check in with your teams. So next slide, please. So really want to share some lessons learned that we've had along the way. I think it's really helpful to help you prepare for any kind of backlash that you get or challenges that you get as you continue on your journey with your teams. To look at how the role of unconscious bias and stereotypes place a burden on historically marginalized people, including those folks on your teams. Recognize privilege and understand unconscious beliefs, racial attitudes, racial identity, stereotypes, and bias as it relates to racism. And understand the importance of inclusive and empathetic leadership in holding your teams accountable. Next slide. So our timeline, we were fortunate enough to be invited to join the birth equity pilot team with CMQCC back in 2019. And most of our beginning of that first year or so was really immersed in learning from subject matter experts out in the Black community about the health disparities and outcome disparities for our perinatal patients, and all women of color in our country. And fortunately, CMQCC during this time, early on in this project, was able to stratify our outcome data by race and ethnicity. And unfortunately, we learned so much statistical information about these bad outcomes, and we found out that we weren't any different at our institution. We did have a gap that shocked us, but we wanted to learn as quickly as we could how to close those gaps. So through all that learning, we looked for other resources, much of which were created and made available to us through the CMQCC. But we moved forward to taking action, and that manifested as us adopting the Respectful Maternal Care Framework from AWHONN to promote a patient-centered communication based on mutual respect. The project asked our nurses to commit to sit with patients and to learn about their perinatal goals, any good or bad experiences that they've had with healthcare, and help put to rest any anxieties they may have or fears moving forward. And the program was very successful, still is successful. We're still learning and implementing to this day as we travel down this road. And as a byproduct of that, we decided we wanted to put our commitment in writing in front of our patients and post them on our walls. So we did develop our commitment for safe and equitable care of our patients. However, in 2023, we held a skills fair and decided to let some of our Black team members come forward with some stories they had shared with our birth equity team about microaggressions they had experienced on the unit. And we thought, well, let's just be transparent. We'll make this part of our skills day. We'll have them come and tell their stories in these small groups to our team members to help them really understand what a microaggression is. And it may not match your intent, but you have to look at the impact anything you say has on another person. And went through it. We felt pretty good about it, got through most of the staff. Everybody felt very thankful for the opportunity to talk this through and ask questions. However, there was a contingent of staff members that were highly offended. And so with the best of intentions, we had to really take a step back and figure out, where did we go wrong? Where did we fail to make our team ready to have these conversations? So we put a team together that helped us figure out who we needed to be to each other first, how we needed to really understand how to treat our colleagues with respect and dignity before we could ever hope to bring that out to our patients. So last year, this team got together and really did a lot of deep diving work with our staff members as well as our leadership teams, and figuring out how do we as leaders adapt to holding people accountable for their impact versus intention, so to speak. So before we felt we could put those commitments up to our patients, we needed to develop a commitment to each other. And so that's really where I want to kick us off from this point. Next slide, please. So during that skills day, where we found that things weren't quite the environment we had hoped we'd be in, we did find that people were really hoping that we could bring this work in and create this incredible care providing to where we're allowing our patients to really have a voice and be heard and seen. And then when we kind of had to do the record skip back to, oh no, we've got to take care of our team first, so everyone's feeling this way, so they have it to give to our patients. We realized changing what we do would be far easier than challenging ourselves to examine who we are and what we believe. Again, I think Dr. Johnson spoke to it, really practicing self-reflection and figuring out what we're bringing to the table before we approach a colleague about something difficult to talk about, or our patients. And understanding that true leadership is allowing yourself to be led by those brave enough to call us to action. It's a scary place to be in. These conversations are so hard, but you have to be brave and just hear that call to action and take care of your teams. Inclusive and empathetic leadership is crucial in acknowledging and addressing the systemic racism in healthcare. These dialogues involve not just healthcare professionals and policymakers, but families, patients, and communities affected by these health disparities. Through active listening and open, respectful communication, we can build and restore our connectedness as humans, kindle respect for every individual, uncover deep-rooted biases and structural barriers that hinder equitable care, and ultimately lead to better outcomes for historically marginalized groups. Bottom line, if we don't learn to talk about differences amongst our teams, there's no hope for achieving equity, inclusion, and belonging for our patients. We have to remember, and again, Dr. Johnson, this was so great to learn about trauma-informed care, that every person, including our staff members, carries their own stories with them, and it filters who they are and how they react and what they believe. Next slide, please. So I wanted to talk a little bit about unconscious bias, stereotypes, and privilege. Next slide. Unfortunately, my video doesn't work, but you guys will get a copy of the slide deck where we'll have a link so you can see this. But in the 40s and the 50s, doctors Kenneth and Mamie Clark conducted an experiment using dolls, all identical except for their color. There was one black and one white. They used these dolls to test Black children's perception of race and to study their development of self-esteem. The subjects were children between the ages of 3 and 7 and were asked to identify both the race of the dolls and which color they prefer. They were asked things like, which doll do you prefer to play with? Which is the nice doll? Which is the bad doll? Which is a mean doll? Which is a good doll? Which doll looks like you? And the videos on, it's just heartbreaking. It's a very short video, but you can see how the stereotypes and the prejudice and discrimination has internally impacted their self-esteem. And it's what we call internalized oppression. It's the socialization of members of marginalized groups to believe or support prejudices about their marginalized identities. And at one point, you could see this little girl and you just, it's heartbreaking. You see shame come across her face when they ask her to point at who she looks like, and she points at the black doll. And it just goes to show you the damage that can be done to these children's self-esteem. And again, now we call it ACEs. I think it's all very connected in that space. Next slide, please. So we had to look at what is privilege. So the opposite of the internalized oppression is internalized dominance, the socialization of members of privileged groups to believe that their social standing is natural, appropriate, or right. So we're looking at privilege. This is unearned advantages and immunities granted and available to a particular group of people. Next slide. So there's lots of types of privileges. If you don't have to worry about how to get up a mountain, you have able-bodied privilege. If you cannot be legally fired from work because of your perceived sexuality, you have heterosexual privilege. If you're confident that police exist to protect you, you have white male privilege. If while growing up, college was an expectation, not a lofty dream, you have class privilege. If you can use a public bathroom without stares, fears, or anxiety, you have cisgender privilege. Basically, if you don't have to think about it, it's a privilege. Next slide. So the big one is white privilege. If you can take a job with an affirmative action employee without having coworkers suspect that you got it because of your race, never asked to speak for all the people of my racial group, I feel welcomed and normal in the usual walks of public life, institutional and social. I can worry about racism without being seen as self-interest or self-seeking. I do not have to educate my children to be aware of systemic racism for their own daily physical protection. If I have low credibility as a leader, I can be sure that my race is not the problem. And if my day, week, or year is going badly, I need not ask of each negative episode or situation whether or not it had racial overtones. Next slide. So this is another video that I'm going to be happy that you guys will be able to watch. This lady went into a grocery store with her sister-in-law, who happens to also be Black, but is very, very light-skinned. So her sister-in-law goes to the grocery store with her. They have their kids with them, and she goes through the checkout line and writing a check, and the grocer is very pleasant with her, takes her check, wishes her a good day, and she goes on. Then she waits for her sister-in-law to come through. All of a sudden, the checker is saying, "Oh, can I see your ID?" So she gives her ID. Then she picks up the book and the bad checkbook and starts looking for her check number in there. And there's a line forming, and her daughter's getting upset because she's not understanding, why is my mom being treated differently? And so finally her sister-in-law came up and said, "Why are you doing this to her? What?" And the checker goes, "Oh, I'm just following policy." And she goes, "But you didn't follow that policy with me. What's changed?" And she goes, "Well, I know you. You've been in here. I don't know her." And she goes, "I just moved here. I've been here 3 months. This woman's been coming here for 3 years." So what was important in that was that her sister-in-law realized that she goes through life differently than her, that she is perceived as a white woman, so therefore she is not questioned as much. So that's the goal in all this, is that we want to make sure that if we are of any kind of privilege, that we are asserting that privilege to help someone that doesn't have that privilege, and trying to make things much more equal, to have that opportunity to learn and be responsible so we can move forward and help people create a more just and inclusive world. Dr. Martin Luther King said, the ultimate tragedy is not the oppression and cruelty by the bad people, but the silence over that by the good people. If we say or do nothing when we are aware of or witness obvious injustices, we are complicit and are guilty of condoning the injustice. So next slide. So what we needed to do when we had to step back is we really needed to understand our team members and what it was going to take for them to feel brave and psychologically safe, to be able to speak their truths without fear of retribution. So to perform that, to assess for psychological safety, you need to ask yourself and your team, if somebody makes a mistake, is it held against them? Is it easy to discuss difficult issues and problems? In your team, are people sometimes rejected for being different? Is it completely safe to take a risk on this team? Is it difficult to ask other members of this team for help? And do members of this team value and respect each other's contributions? I want to invite you all to look at a book called Inclusive Conversations by Mary Frances Winters. It teaches us how inclusive conversations push the boundaries of comfortable, safe spaces to brave spaces. For people to be brave, they need to feel safe. And that was something that we really needed to learn in order for our teams to have these very courageous conversations with each other, to learn and hold each other accountable for their intention versus their impact of anything they may have said. Next slide. So I'm going to go through the next ones because I know we're getting really short on time, but building trust on a team is huge. And so it's about building those relationships and having those frequent, honest communications, because trust is built one interaction at a time. Be impeccable with your words, do what you're going to say, show people you care about them and their interests as much as your own. Speak from your heart. People can always tell when you're not. Offer your willingness to listen. Express your feelings with compassion and understanding, and most of all, own your mistakes. We're in this space, there is just myriad of opportunities to make mistakes and step on your own feet. But we have to be able to have that environment of forgiveness and understanding to move forward. Next slide. So this is the commitment statement that we came up with in the Labor and Delivery Department. We commit to being anti-racist and agree to call it out. We agree to be receptive to feedback, to be self-aware and take accountability for our own actions, to be one team and to work towards that every day, to respect each other and work together for the benefits of our patients. Professionalism doesn't require friendship. That was a tough one that took some negotiating, but those were the words that we finally settled on and agreed to. To deal with concerns as close to the moment as reasonably possible, to dealing with the uncomfortable, to finding a mutually safe moment for individual conversations, to use I statements when expressing a concern or feeling, and to strive every day to be better and grow. Next slide. So what we did is we posted that on our walls in Labor and Delivery, and then we created this feedback station where we take one of those commitments every week and make it a statement of focus. We would put it on the board, and then we ask for feedback from the team. So they could let us know, what does that mean to you? What behaviors are associated with this? And how are you going to live this moving forward? Next slide. So when our commitment statement is violated, we have gone all in on the Just Culture algorithm, which is supported by the ANA. We focus on the behavior. We don't want to label. You don't want to go to somebody and go, hey, I hear you committed a microaggression against this person. The minute you label somebody, they're going to get defensive. You want to describe the behaviors and always come with the attitude to seek to understand. The JUST algorithm promotes a fair and just environment. It balances non-punitive culture with patient safety and employee satisfaction, and improves error reporting and identification, and improves staff engagement. Next slide. So I just want to leave you with words matter, words can hurt, words can do irreparable damage, or words can encourage, words can affirm. Words can include and foster equity, empathy, and inclusion. And I think that's it for me. That's it. Thank you. And if you have any questions, please put them in the Q&A and I'll be happy to address them. Thank you all for your time today.
Thank you so much, Dr. Kelly. We really appreciate your time. Thank you for joining us. Thank you everyone for joining us for the webinar for today. We're really glad that you all were here. And just to close out, since we are at time, I just wanted to let you all know that the California Pregnancy Associated Review Committee is asking for members from the Central Valley to join. So if you're interested, please go ahead and scan the QR code or reach out to Christine Morton with CMQCC, who's our program coordinator. And also just wanted to remind everybody, for those of you who are working with pregnant or parenting individuals, to reach out to them and make sure that they know to update their contact information to keep their Medi-Cal coverage going since the renewal redetermination process has resumed. You can find more information at benefitscal.com or keepmedicalcoverage.org. So again, thank you everyone for coming. Please check out CMQCC's website for more information on toolkits, implementation, and our maternal data center and other ways that you can get engaged. And thank you everyone for joining us. So glad you all were here. Again, thank you, Dr. Kelly, and thank you, Dr. Johnson, for joining us today. If you guys have any questions, please feel free to reach out. We will post the slides and the webinar in the next couple of days on the CMQCC website.